Hi dentists again, this is Mohammed Musa from AFK Study Plan. We're gonna continue with our articles. Today we're gonna speak about the guideline for prophylactic antibiotic for patient with infective endocarditis. This topic is clinically important and for sure from the perspective for the exams, it's important for AFK, for ACJ, even for your last exams. Why? Because like this is life-threatening condition for the patient, and the guideline for this issue has been changed more than once in last 10, 15 years, and still the guideline in North America is different from Europe, is different from Middle East. So as you are aiming to get the license in North America, so as said in Romans, do as Romans do. So we are going to follow the guideline for this one, and as that going on until this guideline has been changed. So we are going to adopt the new guidelines. As usual, get your notebooks, get your pen, write your notes, try your best to answer the question appearing in your screen, and let's dig deep on this one. So before we start, we are going to speak about what is the infective endocarditis, because like I see, and this was my fault for a long time, you are aiming just to get the idea for the questions and to answer it. Oh, and then when you are faced with a basic knowledge or basic science question, you are like lost. You are lost. You feel like I have no clue about this one. So, infective endocarditis is a rare but life-threatening microbial infection of the heart valve or endocardium, most often related to congenital or acquired cardiac defect. And then he goes to speak about it, but like in a simple term, this mean like some patient will have some valve problem or cardiac problem that requires the physician, his cardiac doctor, to give him support inside his valve or maybe replacement for the valve, which is for sure gonna be a plastic part. This plastic part is completely polished, everything is good about it, but as you can think about it, like it's a foreign body inside your heart. So this foreign body usually will have more bacteria than the different part inside your body. So this spot is compromising your patient, and when infection happen, this spot may lead to severe signs and symptoms for this patient. So meaning maybe the patient is doing normal stuff, maybe he's just brushing his teeth hard, maybe he go to the dentist to do some orthodontic treatment or do extraction, and with this type of treatment, there is a transient bacteremia goes inside your blood flow, and your body is controlling this one with the immunity and with this memory before he's good. But for this patient specifically, as this area, as you think about it, is a bacteria over a part which is plastic. There is no defense here working against it. So this area work as a medium which bacteria can be more over it, and then co-infection for every part inside your body, and as I mentioned here, it's potentially life-threatening. Why is this should be mentioning? Because then when you think about it this way, we're gonna speak about the guideline. I think now you can understand it, not like just memorize everything. Okay, and then like then he speak about in a medical term here, pathogenesis of infective endocarditis, turbulent blood flow produced by a certain type of congenital or acquired heart disease may traumatize the endothelium and result in the deposition of platelet and fibrin on the damaged endothelium or endothelial surface. So this part, as we mentioned before, is replaced or repaired or damaged. This part will accumulate more stuff. When accumulate more stuff with less blood supply going to it, so it may lead to more damaging criteria, and the patient cannot help against it. And then odontogenic source of transient bacteremia, as we mentioned before, transient bacteremia caused by very dense group of streptococci and other oral microflora commonly occurs during dental extraction or other procedure, and even during routine dental daily activities. The frequency and intensity of the resulting bacteremia is related to the nature and magnitude of the tissue trauma. Makes sense? The density of microbial flora and the degree of inflammation or the infection at the trauma site. The species entering the bloodstream depend on the endogenous microflora and the colonized the traumatized sites, which we mentioned before. It's replaced or rough because it's partially repaired or not repaired. So the bottom line here, transient bacteremia caused by very dense groups is the criminal here, which is going to like do this harm for our patient. So we should take care of this stuff. Okay, and then the article goes on to speak about this one, as we mentioned, and then he's saying microbial proliferation within a vegetation. Once attached to an anatomic focus, these microorganisms, which is streptococci, stimulate further deposition of fibrin and platelet on their surface. Thus, period. The microorganism can multiply rapidly. Think about it like it's like think about the plaque, and the calculus. The calculus is like providing protection for bacteria inside, which can do more damage. The microorganisms can multiply rapidly, apparently uninhibited by host defense. More than 90% of microorganisms in mature vulva vegetation are unresponsive to antibiotic as they are metabolically inactive. Because they are protective inside, everything is good for them. Thus, infective endocarditis arise from complex interaction between bloodstream microbial pathologies and matrix molecule and platelet at the site of endothelial cell damage. That was the intro for this one. I hope you understand the idea here, because for me, honestly, I struggled long time for this one, and when I just take my time to read it and understand it, it should be easy now. The remaining part should be super easy for you now. Then we are going to speak about a specific condition or medical history for a patient, which will make us think about prophylactic antibiotic. Why I say think? Because it's a two-step decision. It's not like the patient has this condition, so I'm going to give him prophylactic antibiotic. No, it's a two-step. First step is condition is specific. Second step is procedure specific. So not every patient with this condition, he coming to you, you're doing like simple treatment, you are going to give him prophylactic antibiotic, and I think now we understand it why, because we speak about the mechanism of infective endocarditis. So what are the condition? Prosthetic cardiac valve, I think you understand it now. Previous infective endocarditis, and this is signify why it's extremely important to get the diagnosis, to get the medical history from your patient. Congenital heart disease. And here in congenital heart disease, before the guideline was mentioning a lot of condition. Now, no. He's speaking about unrepaired cyanotic congenital heart disease, including palpative, shunt, and conducts. Meaning, before, they have a long list. Now they said, no, we're going to consider unrepaired cyanotic congenital heart disease condition only. Or the patient underwent surgery, completely repaired congenital heart disease defect with prosthetic material or device. This is, again, it's a two-step. Completely repaired with prosthetic material or device, whether placed by a surgeon or by a catheter intervention during the first 6 months after the procedure. So this patient has a history of surgery. He did the surgery, which was successful, completely repaired that defect, but he came to you within the 6 months. So he might be indicated for a prophylactic antibiotic. Or repaired congenital with residual defect, because it's not like a pure science for this part. Some surgeons go inside, repair it, perfect repair, or sometimes they leave some residual defect, because we are not here to judge their work, but sometimes the condition is very hard for them, so they might leave some residual defect. So in this residual defect, you're gonna think about him as a risk factor here, regardless 6 months or not. Last part, cardiac transplant with subsequent cardiac valvopathy, meaning not every patient with cardiac transplant is going to be qualifying for this. No, the question should mention he has subsequent cardiac valvopathy, which leading to it, he will fall into this category, prosthetic cord valve again. Okay, so this is the cases when you think, okay, this patient might be eligible to take prophylactic antibiotic. So these articles did not speak about the treatment, which treatment is going to be qualified for this one. We're going to speak it in the different articles now. But like, let's finish this one first and then go to the other one. So you think about this patient, he has this one, he has this condition. So you think about now he might be qualifying for the antibiotic prophylaxis. So discussion here, he speak about now the vast majority of cases of infective endocarditis caused by oral microflora likely result from random bacteremias caused by routine daily activities such as chewing food, brushing teeth, flossing, use of water irrigant devices, and other activities. So he's trying here to like clear the hand of dentist. He's saying that the dentist is not responsible for every infective endocarditis happening for your patient, because like the studies show it, like it might happen with like forceful brushing of your teeth. Okay, so now for the this article, he speak about the antibiotic regimen is going you are going to give to your patient. So as you can anticipate it, amoxicillin is the line of treatment to be chosen. You give the patient single dose 30 to 60 minutes before the procedure, and you prescribe it to the patient. When you call him to come to the clinic, you ask him to do it. If he didn't do it, when he come, sit in your chair, you give him the medication and you wait at least 30 minutes. What if you forgot to do it and then you remember that? You stop and you give him the medication as soon as you remember. Even if the patient go out of the chair and you discover this, you forgot to do it, or the patient just told you about this now, so you give him medication. So the bottom line here, as long as you discover it, you act upon it. It's not like if question saying, okay, patient didn't tell you, at the end of the procedure he told you, no, just go home. No, you give him the antibiotic. Okay, amoxicillin, the dose is 2 grams, and you should memorize this number. Or if he's a child, so you go for 50 milligram per kilogram, and you give him 30 to 60 minutes before the procedure. Okay, what if the patient is allergic to penicillin or ampicillin? So you're gonna go to the second line. Before clindamycin were mentioned, clindamycin is not anymore. You are going to use azithromycin or clarithromycin. You're gonna give him 500 milligram, and for the children it's 15 milligram per kilogram. If he's allergic to penicillin and unable to take oral medication, so you can think about cefalozine as ceftriaxone. You're gonna give him 1 milligram because this patient cannot take oral. You're gonna give him 1 gram IM or IV, or for kilogram, you're gonna give him 50 milligram per kilogram IM or IV. So for sure, you're gonna take amoxicillin, 30 to 60 minutes at the bottom line. Clindamycin is not anymore. Azithromycin is the second line. Clindamycin is not anymore. So this is it for this article. He mentioned here the stuff, but this article is missing the procedure, which need to be specific. In this one, we are going to speak about the procedure, and this is a very short article. We can just read it now with this one to be in a one topic. So this one, he saying, okay, so this patient has history of infective endocarditis, need protection from this condition. He give him the diagnosis and giving him the prescription. Okay, here he speak again about the same condition, and this article mentioned the condition again. Let's read it with us together. Prosthetic cardiac valve, including transclavicy implanted prosthesis and hemograft. Prosthetic material used for cardiac valve repair, such as annuloplasty rings and cords. Previous endocarditis for sure. Congenital heart disease that unrepaired or repaired completely within last 6 months, or repaired with a residual defect. Cardiac transplant with abnormal valve problem. Okay, so this is the condition. We are going to think, okay, this patient fall in the category which might be indicated for prophylactic antibiotic. And the second option, the second criteria is the dental procedure. Not every procedure we are going to give him prophylactic antibiotic. So this topic is debatable, a lot of debate about this one. So in this article, like, he cut it short for you. So he said, any dental procedure that involve manipulation of gingival tissue or the periapical region of the tooth or perforation of the oral mucosa. This type of procedure is required qualifying the patient to take prophylactic antibiotic. Other than this one is not recommended. And then you're gonna think this is too much. So here he's going to say antibiotic prophylaxis is not recommended for the following dental procedure. Routine anesthesia injection through non-infected tissue. I don't know. We don't do through infected tissue, but anyway. Taking dental radiograph placement of removable orthodontics or orthodontic appliance, adjustment of orthodontic appliance, placement of orthodontic brackets, and shedding of deciduous teeth, and bleeding from trauma to the lip or oral mucosa. So this, as mentioned clearly here, are not like reason enough or justifying you giving the patient antibiotics. And I want you to pay attention to the wording here: orthodontic brackets, not orthodontic. The other stuff of ortho, he might be eligible for antibiotics. And then here speak about the antibiotic regimen: amoxicillin 2 gram, 50 milligram per kilogram for the child, for children. Clindamycin is not anymore. If he's allergic to amoxicillin, so you're gonna think about azithromycin, clarithromycin, 515. And then if he cannot take oral, so you're gonna give him cefalazone 1 gram IM or IV. So this is the guideline. And here, like, one thing you see in the table, like something I think is confusing, but like I can explain it for you. Okay, so he's saying like if the patient is allergic to amoxicillin and then allergic to penicillin or ampicillin, he give him cephalexin. So you think like, oh my goodness, like cephalexin has cross allergy with amoxicillin. How if he's allergic to amoxicillin, we're going to give him cephalexin? This is weird. And then he's going to give you these 2 stars, saying like allergy is 2 categories. Cephalosporin should not be used in an individual with a history of anaphylaxis, angioedema, or urticaria with penicillin or ampicillin. Meaning, like if this patient is allergic to type 4, like delayed type of allergy, so you might, okay, let's try our luck and give our patient cephalexin. But if he's allergy with type 1, anaphylaxis, angioedema, stuff like this, you are going to kill the patient. So you are not going to do this one. So that was all about these articles. I hope you understand the criteria, because I don't want you to memorize it. I want you to understand it. It's 2-step decision to be made that, okay, I'm going to give my patient prophylactic antibiotic. Don't jump to conclusion. First one is the condition of the patient, what we mentioned, and the second one is a procedure. Any procedures that manipulating soft tissue is eligible for this one. Other than that, and what we said, is not eligible for this one. I hope that was beneficial for you. For sure, feel free to share the article with other dentists going to the exam, and feel free to leave a comment or ask any question about this one or a feedback. Thank you very much. Have a good day.